so here we go, everybody. Day number 2. Welcome, everyone. I'm so excited for all of you to be here on the second day of our first One Pair States Online National Conference. My name is Catherine Lewandowski, and I'm a registered nurse here in Washington State. I'm the treasurer of One Pair States, and this has been quite a labor of love. First, I again want to thank all the OPS members who rolled up their sleeves, pitched in, and helped make this a reality. I could try and thank everyone who made this event possible, and I'm sure I will miss one or two, so I won't do that. But just know that if you ever showed up to a planning meeting, your input and expertise at the moment was really so helpful to making this conference a reality. And for the facilitators and chat monitors for the weekend, thank you for giving up so much of your time. It is something that can never be replaced or adequately compensated for. So I am so excited today to finally be bringing this conference to you, or this weekend. The title of this conference is The Path to Universal Healthcare Through the States, which is so appropriate for our organization, as this is what we believe, that this elephant, Medicare for All, is a huge pill to swallow. But if we can cut it up into bite-sized pieces, it makes it a whole lot easier to swallow. And we know that the evidence is quite clear and has been laid bare for everyone in the world to see that we in the United States have a failed healthcare system. None of our statistics have measured up to comparable countries around the world. The last 2 years has certainly shown us that we were in no position to handle a pandemic. But this problem didn't start 2 years ago. For too long, there have been too many unnecessary deaths for our citizens. And yet, in a pandemic, when people were losing jobs, businesses, and their lives, there's been a small group of winners. Corporations who have been siphoning funds from our healthcare system for decades fared very well during this pandemic at the detriment to our economy, our small businesses, our neighbors, and our families. It's time for this to stop. We will only be able to stop this ravaging of Americans if we stand up together against those forces that only seek to profit off of your misfortune. From the beginning, it was my vision to build a conference that shows how we all are interconnected. And from the beginning, I had this vision of a healthy forest with a vibrant and healthy canopy that shelters and protects all the living things under its care. And a healthy forest canopy cannot exist without a healthy root structure. We who are here today are the root structure, and all of our efforts join with yours to feed and nurture the forest. We have a great lineup of sessions for you today, and also a wonderful evening program with a performance of Native Vision by Living Voices, followed by some comments by Vicki Lowe, who is the Executive Director of the American Indian Health Commission of Washington, and also the chair of our Universal Health Commission of Washington, followed by 2 great speakers, T.R. Reid and Wendell Potter, that have been in this fight for a long time and are so supportive of the movement. I don't want you to miss any of that. And so I thank you all for being here today. I very much hope that you can attend as much of the weekend as you are able to. Please remember, though, that each day has a separate registration link. So remember to go and register for Sunday's session also, and that we're all volunteers here at One Pair States. So please forgive us for any bleepers and bloops. And here are just a few reminders. All of you have been muted, but please feel free to introduce yourselves in the chat. And if you can rename yourselves to include where you are from, that would be wonderful. We'd like to request that all attendees please turn your cameras off, and the panelists can turn their cameras on so that you can more easily see who they are. And please put your questions in the chat, and we will pull those out and ask those questions of the panelists.
Hey.
I will also be adding info into the chat, so you may want to save the chat so that you will have that information available after the conference. And again, I want to thank you for being here. So we're going to go ahead and get started. Chuck Panaccio is going to be facilitator for this next session, but he doesn't have easy access to this document that has, where'd it go? Here it is. The very nice introductions for everybody. So I'm going to kind of go through those real quick. Sorry, I had it set up to where I was going to be. Let me get back to where we are. All right, we've got quite a lineup this morning of people. We've got from California Nurses Association and the National Nurses United, Carmen Comsty is here. She's one of the lead regulatory specialists. for the California Nurses Association, which is the largest union and professional association of registered nurses in California and in the nation. She's been a key member of the legislative drafting teams for numerous state and federal bills, including on single-payer healthcare such as AB 1400 to establish the CalCare program in California, as well as on medical debt protections, safe nurse-to-patient staffing ratio, workplace violence prevention, and many others. Carmen currently serves as a commissioner on the Healthy California for All Commission, which is tasked with developing a plan for California on a unified financing healthcare system, including single payer. She also works on regulatory advocacy around workplace protections for healthcare workers, including occupational safety, health standards on COVID-19. Carmen has a JD from the University of California, Berkeley School of Law. And Sam Metz is here from the Oregon Universal Healthcare Task Force. Dr. Metz is a retired anesthesiologist and vice president of the Oregon chapter of Physicians for a National Health Program. He's been instrumental in creating statewide forums about universal healthcare and has counseled many candidates and legislatures into favoring universal healthcare. Marcia Stedman will be here this morning from Healthcare for All Washington. She earned her BA in English Literature from the University of Chicago and an MA in Library Science from the University of Minnesota. Marcia spent the majority of her career in customer relations, most recently as the customer relations manager for a small wholesale travel company. Long interested in equity issues, she turned attention to healthcare reform during the debate over the Affordable Care Act. Shortly after her retirement in 2010, she joined Healthcare for All Washington and found herself in a second career of healthcare activism. She served as chair of the Writers Team and Outreach Committee and was invited to join the board of directors in 2013, where she served as president from 2017 to 2021. Henry Moss, from the Campaign for New York Health. Dr. Moss has a PhD in philosophy with an emphasis on social and political theory. He's been involved in healthcare policy research for the single payer movement with a particular interest in long-term care and currently serves on the advisory board of the PNHP New York Metro chapter. Rana Stoller is a member of Medicare for All Connecticut. Rana grew up in Philadelphia and moved to Southeastern Connecticut in 1977, the year I graduated from high school. After several years living on the West Coast and abroad, now retired, she worked in early childhood education for 30 years in infant toddler programs and as a Head Start home visitor. Since 2004, Rana has been host and producer of the public access TV show Thinking Green, which reports on interesting, important, and uplifting activities in Southeast Connecticut and provides a progressive perspective on local and national issues. Convinced that single-payer universal healthcare could transform the quality of life in the U.S., she became an active member of Medicare for All Connecticut in 2019 and led the effort to pass a new London resolution in 2020. And she currently serves as the Secretary for Medicare for All Connecticut. And John Wiseman is here from MassCare. John is a retired labor community organizer in Western Massachusetts, former coordinator of Western Massachusetts Jobs with Justice, former president of his union, National Association of Letter Carriers, Branch 46, and former coordinator, secretary treasurer, and trustee of the Pioneer Valley Central Labor Council, now an assembly of the Western Massachusetts Area Labor Federation. In retirement, he's been single-mindedly single payer. He co-founded Western Massachusetts Medicare for All in 2017, is the Western Massachusetts co-chair of MassCare, the Massachusetts Campaign for Single Payer Healthcare, and chairs the Western Massachusetts Area Labor Federation Healthcare Committee. Thank you, everybody, for coming. And who would like to go speak first? We'd like you to maybe share 5 minutes or so of what your organization's been doing, things that mostly things that have been successful, where you have made gains. And then after you all speak, we'll try to do take questions from the attendees. All righty?
Catherine, let me just jump in real quick here as the
Sure.
facilitator. We'll just go in the order that you introduced. So Carmen, then Sam, Marcia, Henry, Rana, and John. But let me just welcome folks as president of One Pair States and just say that our organization's been around since 2009. And our purpose, our mission is to achieve the gold standard which is national single payer healthcare for all, guaranteed healthcare for all. And we strive to work at all levels, looking for opportunities. That's why we're focused initially or primarily on the states, but we also look at the regional opportunities, something embedded in Ro Khanna's legislation, the State-Based Universal Health Care Act, something that we want folks to continue lobbying on. We also work at the national level in support of Pramila Jayapal's bill, as well as other progressive, even incremental, positive incremental changes to our healthcare system. Something that was highlighted yesterday that ought to be highlighted again is that during this pandemic, when it came to the coronavirus, we actually moved in the direction of single payer healthcare, right? We got healthcare to people during an urgent issue, an emergency. So we've proven that we can do it like the rest of the world. Now we need to take that final step. So with that said, I just want to welcome everybody into the room. I want to thank Catherine and the other folks who put this conference together and really express deep gratitude. If you have a link for the program today, please share it now during the program to bring other people into the room so that we're not just talking to each other, so that we're expanding our audience and that we're doing intersectional organizing across all areas of social justice so that we can bring folks into this process and we can join with them as well. So thank you again, Catherine. Let's start with Carmen. Carmen, really honored to be with you and the other participants in this room. Love to hear your thoughts, especially on what's happening in California and a pathway forward. So thank you so much, Carmen.
Yeah, thank you, Chuck. Thank you, Catherine. Good morning, everyone. Good afternoon, everyone who's on the East Coast. I'm calling in from Ohlone Land here in California. I think many of you know that in California, we've kind of been on a bit of a roller coaster this past year in our efforts to win single payer. But to give the 1-minute version of what happened for those of you who haven't been paying attention to the nitty-gritty details. Last February, the California Nurses Association, we worked to introduce a single payer bill in California's Assembly, AB 1400, which would have established a state single payer system called CalCare. And long story short, after the bill was held up and not referred to committee last year, we pushed hard for a 2-bill strategy, pushing a separate legislation on the policy of single payer and the financing of single payer. So in rapid succession, just in January, 2 months ago, we introduced a second bill, this one on financing. And doing so, we were able to get the policy of CalCare, AB 1400, referred to committee. And by the end of the month in January, we had passed it through the Assembly Health Committee and the Appropriations Committee. However, we were not able to get it to a vote on the floor after the bill's lead author pulled it from the floor at the 11th hour, at our objection. CNA, we have a statement up online if you all want to read it about, the incredible and indescribable disappointment and frustration that we have because we didn't get a floor vote. I'll drop a link in the chat, or maybe I see one of my colleagues, maybe he can drop the link in the chat. But for today, I really want to focus on how the policy of CalCare and what we've tried to do to kind of break loose the policy of single payer from the quagmire that moderate Democrats have created by saying, I support single payer, but we've all heard this, I support single payer, but. So, in putting the bill together, we really wanted to revamp the bill itself. There was about a 3-year period between the previous single payer version of bill in California and when we introduced AB 1400. And so what we ended up doing in California is that we did 2 big things. One, we aligned the California bill as much as possible with the Medicare for All bill in the House. We both worked on both of those bills. As many of you know, the California Nurses Association and National Nurses United We both work on California single payer and Medicare for all. So it made sense for us to align the policies as much as possible so we can coordinate both our campaign, our messaging campaign between CalCare and MFA, and so that we can grow our grassroots organizing campaign on both levels at the same time. And, I think this has been one of the things that has been key in developing district leaders in California and building the movement's capacity to have the kinds of really deep one-on-one conversations to organize ordinary people, to bring more people into the movement. This kind of movement building that we know is really necessary for single payer. And the second thing that we did was that we started to build in the bill itself. We started to build what I like to call the how of state single payer. So like, for example, we have a really detailed section on hospital payments through global budgeting. We incorporated existing California regulatory systems where possible. And we started to build in provisions about health equity and how we could use single payer to address health disparities. And generally, our CalCare campaign, we've really started honing in on the arguments about policy. And I think this is where we've really had a great deal of success. And one of the ways we've been able to do this is through the Healthy California for All Commission, which, as Catherine said, is a commission established to talk about, quote, unified financing, including single payer. Now, the commission, which I sit on, it could have been an obstacle to state single payer, but we used it, and we've used it as an opportunity to both educate key legislators. So we have health committee chairs on that committee, and also importantly as a place to build the leaders in the grassroots movement for single payer in California. Well, we've used it as a way to get more and more activists in the movement to be comfortable and confident in talking about and responding to all the gotcha questions on single payer that I know all of you have heard before. How are we going to pay for it? What about this? What about federal waivers? What about all these things? So, there's hours and hours of videos of our activists and me pushing back hard against some of these really bad faith policy arguments against state single payer, federal waivers, to health insurance plan intermediaries, racial health equity, home and community-based services. We just had a meeting on cost sharing, and so on. And I think, addressing these questions about the how of state single payer are really, really important for us as a movement. And that, I think it's a testament to where we are at as a movement also, because the questions from the politicos that we're hearing now are not necessarily about what is single payer. And for the most part, it's not about why we need single payer, but the questions that we're hearing now are about how is single payer going to work? How are we going to get a program off the ground? So we've really, really tried to build these kinds of campaigns around making sure that we're answering these questions so that we can build people's, people want to know, how is this going to work? How are we going to get there? And we're trying to build the movement around making sure that people understand, what single payer, how it's actually going to work when it comes when it gets into effect. And to quickly wrap up, I just want to underscore that this policy and legislative work that I do all the time, it goes hand in hand with our grassroots organizing. My colleague from CNA, Phil, he's going to talk about organizing a little bit later today. And the policy and the organizing, we are in lockstep, and this is absolutely critical. And here in California, despite the losses we've had, I think we've seen incredible growth and successes in our organizing campaign. And we all know that the road to justice is not an easy one, and it's a long one. So my call for all of us is really that we all work together across all of our states to keep our movement sustainable, both when we have our wins and we have our losses. And it's always worth repeating to have these kinds of conversations that we're having today, that we are one movement and we are all in this fight together, no matter what state we're in. And, us here in California, we're ready to continue the fight of healthcare justice despite the loss earlier this year. And we're ready to fight with all of you across the country. I'll save my other comments for Q&A. Thank you all so much.
Thank you, Carmen. That was wonderful. That's quite a task to jam as much information as you did in. Questions are already filtering in. You can maybe take a look at the chat if you have an opportunity. And then we'll swing back around with Q&A after all the presentation. Thanks again, Carmen, for all your great work. We're in total solidarity with you. Somebody for myself who went to high school and college in California, all in, everything, absolutely. Sam Metz from Oregon. Sam, please, about 5 minutes of presentation, and then we'll go to the next presenter. Thank you, Sam, for coming. You may need to unmute. Sam, are you with us? Is Sam Metz in the house? Does anybody see Sam? Okay. Are you there, Sam? No. Okay, we're going to swing back around to Marcia Stedman from Washington State. Marcia, can you go? And then we'll pick up Sam when he comes in. Marcia?
Yes, yes, I'd be happy to go. Say, I have a PowerPoint. It's about 5 minutes, so I would wonder if I can share my screen with you all. Is that possible?
You should be able to, yes.
Okay, so if I can get permission. Okay, let's see, slideshow.
And Mike, can you just maybe text or phone Sam, see where he is? Thank you.
Okay, well, I'll just start here and go quickly through this. It really helps to organize my thoughts if I have something to look at and talk about. So I just really am very appreciating your states and how you connected us all from all of us your states members throughout the years to share tactics and strategies and successes and commiserate when needed. But so I have Washington State has a dual kind of pathway. And so I'll talk about the Universal Healthcare Commission that's just been recently started meeting and current legislation that actually is helping us go farther on that. So we have multiple simultaneous pathways to our shared goal. It is the Universal Healthcare Commission and other legislation that includes SB 5204 and the Washington Health Security Trust. In Congress, we back the State-Based Universal Healthcare Act. We need that. And the Build Back Better package, of course, and also Medicare for All. So I want to tell you about the Universal Healthcare Commission. It's charged with creating immediate and impactful changes in the healthcare access and delivery system in Washington right now, to the extent possible, and also preparing the state for the creation of a healthcare system that would be universally financed. So right now, they've adopted their mission last week at their third meeting, and they will be increasing access to healthcare and universal coverage, reducing healthcare costs, reducing the health disparities, improving the health and well-being of patients and the health workforce, improving quality, and preparing for the transition to a unified healthcare financing system. Financing is usually the tough point on any legislation for universal healthcare, and that's something it's going to be folded into the commission's work. So it's a permanent and funded commission. There's 15 members, 4 legislators, 2 from each major party, and state agency representatives that are responsible for carrying out the program once it's set up, and have really good expertise in designing it. Equity, healthcare delivery, and insurance agencies of the state government. And the exciting part is that there are 6 members of the public on this commission, about 2/3, and they, including the chair, Vicki Lowe, who you'll hear from later in this today, and they were all recommended by universal healthcare advocates, including Healthcare for All Washington and Healthcare is a Human Right Washington. So we have great hopes for this commission. It's going to take a while, It's a permanent commission, but they're going to get to work right away. They're going to have advisory committees on financing and other areas to advise them. Federal waiver application process must begin within 60 days of the availability of the waivers. We have the ability to request Section 1332 waivers right now in the Affordable Care Act. And of course, Ro Khanna's bill would really smooth the way for us. And we really just need that. And then while the commission is meeting, agencies that have authority may implement specific elements of any recommendation made by the commission without additional legislation being required. So it could be a faster process for the steps that we can take. So they'll be busy working this year until November 21st of 2022, when they will be required to provide a synthesis of analyses already done on healthcare finance on existing healthcare measures in our state, and the strategy implementable changes that I just mentioned, data healthcare cost transparency board and other boards that are tracking transparency and costs across various aspects like the pharmacy and primary care, and an inventory of the key design elements of a universal care system that I've gone through before. I want to quickly move here. Oh, so the work of the commission has been guided by the 2019-2020 Universal Healthcare Work Group that prepared the way. The graph you see here has got a lot of detail on it. I won't read the whole thing, but you can see that the actuaries, for the work group, really prepared and studied a variety of all the implications of a universal healthcare system. The top choice of the work group members was Model A, a state-administered and funded universal healthcare system. The actuaries found it would save billions, in 1.5 billion the first year and 5.5 billion every year thereafter. So that's a strong, compelling argument for our Model A. The other models were the Model B was administered by this, designed by the state, but administered by private insurance companies as now, with premiums being still continued to be charged. And Model C was the status quo, where we have multiple payers and programs and plans all over the place. So the challenge is the feasibility, and single payer universal healthcare advocates really took exception to why did they make feasibility so red and so such an obstacle. But I think we understand from the experience of other states and our own experience that it's really hard to get a change, this transformative change that we really need into our system. So that's why we've gone the route of a commission that's going to decide and design the system. So the way we can actually ensure that the commission fulfills its charge is to attend and actively participate in the open public meetings of the commission and push the urgency of the work. The pandemic has really helped us in that area, how urgent it is. And we work with coalition partners to identify people ready to offer their comments in testimony or in writing to the commission. We have Healthcare as a Human Right is a coalition that's working together with labor, advocacy committees, reaching out to faith communities, and just unify people and get people excited, the grassroots involved in this kind of work. Educate the public, providing meeting information, updates, and recaps, and recommending members to the advisory committees as they're formed. And our goal is to promote the Washington Health Security Trust as a framework for the system design. The Washington Health Security Trust is a plan that Healthcare for All Washington developed years ago. And we started out as an initiative back in 2000. It didn't get enough signatures to make it for the ballot. So we turned it into a bill, and which actually didn't go very far. It had a few hearings over the years, but no action was taken. So what we did was we partnered with our legislative champions, healthcare committees, and we, over this last few years, we have built solid relationships with the key leadership of the House Healthcare Committee and Senate Healthcare Committee as well. And we have an open door to some of the ranking minority members of these committees, so that we got that enabled us to actually get the work groups set up that met in 2019 and 2020, enabled us to get the commission signed into law and set up. And now what we're doing is working on legislation that will lower costs and improve access to healthcare, which will be needed for the work of the commission, and to actually lower costs is what we need across the board. I mean, we had a conversation with our 9th District Congressman Adam, 9th would be, sorry, excuse me, I'm forgetting his name right now, but anyway, his request to us was that really we need to lower prescription drug prices. That's really what we need to do, and prices across the board. So that was our focus 2 years ago, and we continue on that focus to get insulin costs down, and to establish a prescription drug affordability board that will monitor prices of drugs, and hopefully eventually set up a penalty system if prices rise too high. Then the prescription manufacturers will need to pay a fine to the state. We hope that will work for them, bringing them into line. And we want to be increasing the primary board and commission capacities for real people to be members of future boards and commissions. We need to track primary care statewide spending so that we can determine where we can need to increase that. That's the key to a universal healthcare system. And if by expanding charity care, we can get more people enrolled in the public medical assistance programs or the Washington Health Benefit Exchange, and thereby lessen the burden of charity care on hospital systems, and also just expand people that have access to healthcare in our state. So it's been a long road so far, and it's going to be a little bit longer, but the public opinion in Washington state is that about 2/3 of our state residents polled believe that universally funded and financed and set up system of healthcare would be the best way for our state to ensure everybody and provide care for everybody in our state. Thanks so much for listening, and I'll be happy to take any questions when that time comes.
Okay, terrific, Marcia. Thank you so much. Appreciate it. And this slideshow is available to folks?
It can be available.
Okay. If there's a link you can maybe drop in the chat, that'd be great, so that folks can get
It's not posted anywhere yet, but we'll do that.
And also for all the participants, if you could drop your email address. There are a number of folks in the background who haven't self-muted. There's some background noise I'm hearing. So people, please, if you could self-mute. Also, if you could rename yourself to let us know where you're from, that would be terrific. Has Sam entered the room yet, Mike? Sam Metz? Is Sam with us?
He's on his way, but not yet.
Okay, so then at this point, we'll turn to Henry Moss, who will speak to the New York Health Care Act. We heard a little bit from our prime sponsor yesterday, Representative Gottfried. But Henry, tell us what's happening in New York and how we can help, and what are some of the key highlights that we can take away from what's happening in New York. Thank you, Henry.
Thanks, Chuck. Thanks, Catherine. As Gottfried pointed out yesterday, New York now enjoys Democratic supermajorities in both state houses, due largely to successes in the Senate races in 2018 and 2020. The Assembly, which is the larger house, has also had supermajorities on the bill, the New York Health Act. The majorities have been so strong that the bill has actually passed 4 times over recent years by 2-to-1 majorities. The problem we have is with the Senate, the smaller Senate. Even with the Democratic supermajority, we only have a a one-vote majority on the bill. The Senate Majority Leader, Andrea Stewart Cousins, who has expressed support for the legislation in the past, has taken a pro forma neutral stance on the bill. And despite strong support on the Health Committee and other relevant committees, she did not allow the bill to move forward last year. And it's unclear whether she'll allow the bill to move forward this year. Unfortunately, some of the co-sponsors on paper, as Assemblyman Godfrey pointed out, are hesitant and raising questions. I suppose this is good news because as the bill gets closer to passage, that kind of thing happens. So it's created the need for two-track strategy. On the one hand, we'll continue to do our broad-based grassroots organizing efforts, concentrating on labor at this point. And the sponsors, Gottfried and the Senate sponsor, lead sponsor, Gustavo Rivera, will continue to work to try to shore up the Senate support and take some of the soft supporters and make them into hard supporters. We'd like by the end of 2022 or 23 at the latest to present our new governor with a two-house bill, which would be a huge, huge step forward. We also would like this year to get hearings in the Senate committees to push that momentum further. Now, as most of you know, New York City is the dominant force in the state government in New York, which of course is good news, but as Godfrey pointed out, New York City legislatures are closely tied to the powerful municipal employee unions, teachers, City University of New York professors, AFSCME, DC 37, et cetera. And a number of the legislators who have worked closely with those unions are hesitating, and they want to see if Gottfried and Rivera can convince these unions to give up their existing plans and move over to the New York Health Act. This is what's causing the blockade, as Gottfried pointed out yesterday. We also need to shore up support in the near suburbs, where Democrats have taken over a number of state Senate seats. The problem there is they're wealthy suburbs, and a progressive tax ends up being pretty stiff on the upper rungs of that progressive structure. So we're getting a little bit of pushback there, but not nearly as much as we're getting with respect to the labor unions. The unions in the past have been ambivalent. Yeah, we like the New York Health Act. Yeah, we like a lot of the new benefits. We like the lack of networks. We like the no cost sharing, no deductibles, and so on and so forth. But as we've gotten closer to success, they've gone from ambivalence to active opposition, which was kind of surprising to us. They've sent letters to state senators, state assemblymen, the governor, and so forth, saying they actively oppose the bill. They understand that the current healthcare system is broken. They understand it's too expensive. They understand that it's wasteful and even dangerous. And yet, as union leaders, they've been unwilling to let New York Health Act go to the next level. So I thought I'd provide 3 or 4 of the arguments that they're giving. It might be helpful around the country to see if you're getting similar arguments, but it'll also be helpful to understanding the mentality that exists in unions and other organizations when it comes to their benefits. A load of noise there. We have support from the labor movement. Obviously, the New York State Nurses Association is the driving force behind the campaign for New York Health. SEIU 1199 on paper supports the bill, but they have not been active. So here's what we've been hearing from the union leaders. The first argument: we've sacrificed wage increases over many years to win very good premium-free, low-cost sharing health plans with decent networks, even in the face of legal restrictions on our ability to strike. While we like the package being proposed by the New York Health, including its long-term care provision, It's not enough to get us to hand over the future of our health benefits to an unreliable state government. We want to carve out in the bill or some serious special consideration for all the sacrifices we've made over the years. That's the first argument. It's very common. It was actually in the letter they sent around. Second argument, when we negotiate a contract, we can spell out to members precisely what members will get and what they'll be paying. The New York Health Act does not have a fully articulated financing plan, only an outline. I can't take that to our members. The third argument, we've built up supplemental programs over the years where the government provides supportive funding for optical, hearing, dental, orthotics, and many other benefits. These programs have generated large staffs, leases on office buildings. What will become of all that? And the fourth argument we hear relates to retirees. We have strong benefits for retirees, and I'm on a retiree plan for the United Federation of Teachers. What happens to those benefits if a retiree moves out of state? While the bill says they can remain on their prior state plan, there are too many uncertainties. Will those plans still exist after implementing the New York Health Act? And at what cost? Now, we still have organizing, this is not all negative. We still have organizing advantages in this situation. Health prices are continuing to increase. The government employers have begun putting pressure on public employee unions for givebacks. Most recently, as some of you know, they're trying to force municipal retirees into a Medicare Advantage plan, which they claim will save $600 million a year. And there's the impact of the pandemic, which we heard about a great deal about yesterday. There are also there are caucuses in several of the larger unions that have endorsed the New York Health Act. So the potential is there. Governor Hochul, the one who replaced Governor Cuomo, also appointed Brian Benjamin as a lieutenant governor. Brian Benjamin was a state senator who was a co-sponsor of the New York Health Act and was a protege of the original lead sponsor of the bill, whose name is Bill Perkins. Hochul also appointed Mary Bassett to be the state health commissioner. Mary Bassett is a longtime Medicare for All supporter. She supports the New York Health Act, and she sits on the advisory board of the PNHP New York Metro chapter. So that's good news. On the other hand, Xavier Becerra also supports Medicare for All and probably the California Act, but that hasn't led to any major breakthroughs at this point. We also have the advantage of not requiring a public referendum the way they do in California. This is important because it doesn't give over the opportunity for big insurance, pharma, and hospitals to run the kind of campaigns and fear of tax increases they've been able to do in Colorado, California, and other states with public referendums. We're strictly a backroom deal state at this point, with a lot of influencers through unions and so forth. So there's a lot more to the story in New York than what I just told you, but I thought the New York union situation would be particularly interesting. But later, if we want, I can tell you things that are going on in other aspects of the organizing.
Thanks so much, Henry. That was wonderful. That was very detailed and nuanced. I think there's a lot that I learned there. I'm sure a lot of other folks would say the same. So thank you for that. And any links you have to any articles or write-ups, anything like that, if you could drop those in the chat, I'll just keep repeating that for folks who are presenting. Thank you again, Henry. Sam Metz has now joined us. Sam, I'll swing back to you to discuss what's happening in Oregon. Mike, how are we doing on time? Mike, do we need to narrow things down a little bit, or Mike?
Yeah, try to get back down to 5-minute presentations.
Yeah, so Sam, if you could keep it to 5, that'd be great. Sam Metz from Oregon. Thanks, Sam.
Thank you, Chuck. I apologize for my late entry. Oregon has several projects going on simultaneously. The biggest one is that in 2019, the Oregon legislature created a task force to design a single payer system for Oregon. This sounds pretty good. There are some caveats to this. We are due to give a report back to the legislature at the end of this year. The legislature is not obligated to either read the report or do anything with it. However, our lessons in the report will be apparent to the legislature. We also have on the ballot an amendment to the Oregon Constitution called the Hope Amendment. It's the brainchild of a late great state representative, Mitch Greenlick, who for decades was the thought leader in the Oregon legislature. As what many people consider a misguided attempt to honor Mitch, this ballot measure, if passed, would obligate the legislature to provide timely health care to everyone in Oregon. There are enough caveats in this bill, such as it can't interfere with any of the other state functions, that it is, for the most part, toothless. It's an aspirational bill, and it has riven the single payer movement. Those who fear that if this bill is passed, the legislature will be sued by everyone in Oregon who does not get timely health care. That's a lot of people. And that this will motivate the legislature will do anything to stop the lawsuits, not something to get better care to more people for less money, but which makes the legislature more defensible in court. We need to keep in mind that desperate people don't become more rational. Then there are others who fear that if this ballot measure isn't passed, it will be taken as evidence that Oregonians just love their health care and don't want anything to change. So it's a damned if you do, damned if you don't. Many of us are hoping that this ballot amendment will be disqualified because it hasn't been a resident in Oregon for 3 years. It's an inside joke because one of our leading gubernatorial candidates was disqualified from the ballot because he could not prove he lived in Oregon for the past 3 years. There are many lessons that we on the single payer task force have learned about right ways and wrong ways to attempt single payer health care. And I would share most of these with you in a Q&A if we have that. Some of the biggest lessons for me, here I'm speaking as a member of the committee talking about personal experience. I'm not speaking as a formal member of the committee. First, right now, it is federally illegal for any state to create a single payer system. To pool all of the private spending in healthcare in a state now, which would include not just premiums, out-of-pocket payments, but also self-funded plans and employer spending, would very likely violate ERISA, the Employee Retirement Income Security Act of 1974, and would be challenged in court. It would also be exceedingly unlikely that any single state could get all of the waivers required from the big federal funders of healthcare, such as Medicare, Medicaid, the Affordable Care Act, and be able to fold it into a single fund. This is especially difficult in behavioral health. Behavioral health in Oregon is funded by close to 100 different government agencies, all of which are tenuous, all of which change year to year. It would be valuable if the Oregon legislature appreciated that we need federal enabling legislation if a state wants to create single payer legislation. Make this a bipartisan issue and call out to all of Oregon's congressional delegation, including our one Republican, and say it's time to hold hands and pass a states' rights universal health care bill. which would be very much like the Ro Khanna Bill 3775. A second lesson is if you want a single payer plan designed for a state, call on the professionals who know how to do this. Our task force is filled with eager, ambitious, highly intelligent amateurs who have never designed a healthcare system before. We know what we want it to look like at the end, but we don't know how to put it together. Consequently, we have not spent our time or money wisely. If I were to do this over again, I would appoint the same crew of dedicated advocates to oversee a professional organization. And there are many who could propose a single payer plan, and we would review it for equity, justice, and the various other values that we want incorporated into it. There are other lessons, but I'll wait for Q&A, or you can contact me directly. Thank you.
Thanks so much, Sam. Again, drop your email address if you would in the box as I'm asking all other presenters and any relevant links. Sam, thanks so much for the report. Let's see, next up we've got Rona from Connecticut, Medicare for All Connecticut. Rona?
Hi, thank you for inviting me. Medicare for All started about, Connecticut started about 4 years ago as a grassroots group that initially focused on lobbying our representatives in Congress, but has gradually been moving towards a lot more attention toward working at our state to try to enable a single payer program in Connecticut, both to help reduce the disparities in our state and to help build a national critical mass to move things forward in Washington. Connecticut has some unique challenges. Hartford is the insurance capital of the world. So insurance companies, pharma companies have a tremendous amount of lobbying power here, even more than in other states. Our legislature has long and short sessions on alternating years, and new legislation can really only be introduced during the long sessions, which are in odd number years. So it's kind of a short window to get something big approved. Even though it's wealthy, Connecticut has one of the worst wealth gaps in the country. So any legislation that talks about progressive taxation, someone else mentioned that, is bound to get be controversial. And I don't know if it's a plus or a minus, but we have no mechanism for ballot initiatives at all. So like New York State, it's strictly a backroom state. Its advantages, though, is Connecticut in 2012 did restore public administration of Medicaid. And in that decade has saved a lot of money. So those positive results can be used to deflect arguments that government can't make things better. There have been groups working on healthcare in Connecticut off and on for at least 20 years, so it's not a new topic. Insurance companies have kind of overreacted to public option proposals in Connecticut, and that's caused many advocacy groups that initially did not really support single payer because they thought a public option approach was more practical, are learning that a public option approach is not practical, that it's more practical to go for what you really want, a single payer program, because you can, because that offers cost savings, overhead savings that public option does not. And Husky, which is Connecticut's Medicaid program, has a very positive perception in the state. So Medicare for All Connecticut is currently working on many fronts. Internally, we're in the process of applying for a status as a 501c4 organization. We're supporting the adoption of municipal resolutions advocating for Medicare, expanded Medicare for all on both the state and national levels. My town of New London was passed the first resolution in 2020, right before the pandemic. We have been developing questionnaires to inform endorsements of candidates for office and are starting to endorse pro-Medicare for all candidates at everything from the municipal level up through congressional candidates. We've been meeting with progressive state legislators to pass bills in Connecticut's legislature. In the 2021 session, we had 2 bills. One of them, House Bill 5340, was a detailed roadmap to implement a state single payer program. And it had a lot of co-sponsors, but did not go far. We also had a committee bill, Senate Bill 1090, that authorized a study of the economic impact of a single payer system. And that got much farther. It was approved as a committee bill, but it got stuck in appropriations. Because it did get approved as a committee bill a year ago, there is still a potential for bringing it back even in our current short session, which really limits what goes to the floor. And we're still strategizing with the legislators how to figure out the best way to earmark the funding that's associated with the study, even though it's really a very small amount of money. Increasingly, we find ourselves partnering with other state advocacy groups for healthcare and other social justice groups to expand coverage options and contain, consumer costs in healthcare. There is a bill that would expand Husky program to immigrants who otherwise qualify. And we are partnering with a few immigrant rights groups to try to get that through. We also find ourselves, unfortunately, fighting attempts to have pass regressive healthcare policies. Recently, in one of the governor's executive orders allowed for making innovations in Medicaid and Medicare both. And there are bills that, and they're not bills, there is a roadmap that would change payment to providers of healthcare that really would functionally shift that whole Medicaid public risk sharing onto physicians. So we find ourselves all too often fighting regressive attempts to increase the private sector's influence on our healthcare, while trying to support ways to bring new groups under the public umbrella through Medicaid. And I guess I'll stop there. We'll just maybe in the QA, if there are some specific questions, we can talk about it, but I don't want to take too much time. Thank you.
Oh, absolutely, Rana. Thank you. And as one of our board members over at One Pair States, and just a quick shout out to our good friend Stefan Romdor, who, along with you, launched Medicare for All Connecticut and recently launched Medicare for All Florida. So we're in the deep South, which is awesome, amazing work that's being done out there. John Weissman from Massachusetts. John?
Thank you. Thank you for the invitation to this program. What I've prepared is by way of introduction, because I don't think we've worked very much together over the years. So let me just dive right in.
Yeah, and please stay with us. Thank you.
Thanks. In 1995, the Healthcare Committee of Massachusetts Jobs with Justice, a workers' rights coalition of of labor unions, community groups, student groups, faith-based groups, started the Massachusetts Campaign for Single-Payer Healthcare. That's our official name. MassCare is our nickname, but it could also be the name of the single-payer institution that we're trying to create. But instead, we call it the Massachusetts Healthcare Trust. Our coalition is now 83 organizations statewide, including the Universal Healthcare Education Fund, which is our 501c3. So I thought every now and then I might have a link to help you dig deeper into what I'm saying. There's that one. Of this coalition, 19 are labor organizations, including the nurses and the teachers, 2 teachers unions. They represent the majority of union members in the state, where 13% of workers are union represented. Labor has its own committee within MassCare. We have a fully formed bill in the legislature, meaning it addresses all aspects of setting up and running the healthcare trust, including its revenue and spending, all vetted by experienced law writers. Having by constitution, a flat income tax, which politics will not let us raise for the trust. We use a payroll tax, as Medicare does. Employees pay 2.5% of payroll after the first $20,000 per year. UMass Professor Gerald Friedman is our economist, so I will just link to his report. And he's done this for other states too, as you know. So each legislative session, we increase the number of co-sponsors, and we now have 40% of the House and 43% of the Senate. And co-sponsors are 62% of the House committee, 57% of the Senate committee that meeting jointly hear our bill. But the Commonwealth of Massachusetts is misnamed. It is not a democracy. Legislative leadership controls all outcomes. So our theory of change is different, and it's expressed in this link. Unfortunately, over about 24 years, we have the experience of lawmaking in the State House and at the ballot box, as well as running non-binding ballot questions. We believe that to reform an entire economic sector, we must organize the largest grassroots movement Massachusetts has ever seen, and that legislative work is just a part of that. We are organized as a 501c4 with a board currently of 18, with 8 organizational seats. We've designed our grassroots organizing around legislative districts and leading organizations such as labor, healthcare, community, faith-based, and business. A hub is our basic unit of grassroots neighbor-to-neighbor outreach and education. Our goal is to have at least one hub in each of the 160 state representative districts carrying out effective organizing work. Of course, each state rep district is entirely or partly in one or more of the 40 Senate districts. There can be more than one hub in a district, and if so, those hubs should coordinate their organizing and lobbying activity. One hub can also cover more than one district if they have the capacity to do so. A hub can be a group specifically advocating for single-payer healthcare, or it can be part, such as a committee or task force, of a multi-issue organization. A hub's primary responsibility is to build support and mobilize within their district for the legislation, lobbying, and if need be, replacing state reps. They also work in collaboration with others regarding state senators and members of Congress. Hubs and organizations form the coalition. The MassCare Coalition representatives sit on the Grassroots Organizing Committee, we call it the GO, which determines the campaign strategy and tactics. Each hub or organization gets one vote, but can send as many reps to the GO as they want. For most of this work, the coalition will be running most of this year The coalition will be running non-binding ballot questions in legislative districts. Most will be run where there is a non-co-sponsoring incumbent, including a few in leadership or an open seat. This work is also part of ongoing work to build hubs, grow the coalition, and diversify the movement. That is enough for now. I'll see if there are any questions, but I will paste in a link to what I just said.
Terrific, John. That was really awesome, as is the case with all the presenters. And I'm really thrilled that you brought up the question of strategy. I think this is where One Pair States has been centered on our work for the last few years, which is getting out of our silos and doing fusion organizing and working across all bands of social justice efforts and movements and campaigns. So that's the only way we're going to build a capacity to win. So I'd love to hear more about your work as the other folks offered in our conversation. So Mike, how are we doing on time? Just to be realistic here. Yeah, are we doing okay? How much time do we have for Q&A?
No, we're using up the break time, which is fine. So just keep next. I think we're through the presentations, right?
Yeah. So our chat monitor, I mean, I tried to track the chat as much as I could to come up with questions, like questions that overlap and can be handled by all the presenters. Are questions ready for me?
Well, I've got some here.
Okay, Catherine.
Chuck, let's see. I think actually, Carmen, that question got answered in the chat. So, but I don't know if she wants to read it. Does the 1332 waiver have an expiration date of 5 years? And if so, does it have a renewal? And what about if the federal government is hostile at that time? Does she want to maybe talk about that?
Yeah, sure. I put it in the chat, and I think, the questions about waivers, I think just to kind of give everybody a sense of like what we've been doing on waivers in California. So our lead author, actually, he met with Secretary Becerra earlier this year or last year. And one of the things that Secretary Becerra's office, the Secretary of Federal Health and Human Services, his office actually said and agreed with us that we do not need Congress to pass a new law creating a new waiver program for Medicare and Medicaid. So I think that's game changing that we have an HHS right now that says that we are ready and willing to take applications for a single payer program. And it basically said we've looked at your bill, AB 1400, and if you apply for it, we'll consider it. And we don't need any additional authority from Congress. So I think that's a really, really big game-changing type of conversations that we've had with on the federal side for federal monies, and with the specific ACA 1332 waiver. So like a lot of other waivers that exist for federal funding that exists right now, that states, almost every state has a federal waiver of some sort. They expire after, they need to be renewed after 5 years, but it's not uncommon for HHS to renew these bills after these waivers after 5 years. And the 1332 waiver application itself contemplates a 10-year lifespan at least of the program, because it requires the state to provide a 10-year budget. So, in concept, they are really willing to renew it. And if there is a conservative presidency that rescinds state waivers for federal funds for a single payer program, there is actually good case law, because the Trump administration tried to rescind a bunch of good federal programs like DACA. And there's a really good Supreme Court case that came out in 2019 that really limited what future presidents can do to rescind programs where there's some reliance of individuals on those programs. And and I don't want to sugarcoat it. A future conservative president could try to rescind a state single payer waiver, but we do have some case law that is on our side, that's Supreme Court case law. But, you know, I'm a lawyer. I know how bad the courts are. You know, we can't necessarily rely on it, but also we can't have the courts and theories about what a court may or may not say become a complete barrier to pushing single payer forward.
Agreed. Okay, let me see. Let me grab a question from that's directed to somebody else. Marcia's got a question in here. I think it was regard to one of the graphs she had. It's are the Washington 5.5 billion savings after expanding coverage and scope of benefits for all? And has there been any assessment of where there may be shortages of doctors or hospital capacity to plan now for addressing that, so when access increases, there are not waiting lists? I suppose anybody can answer that second part.
Marcia?
Hi, yeah, sorry, I was muted. So the first part was about how they got to the 5.5 billion savings. And this was from modeling how much they expected the system to cost, and what is was from the number of residents in our state, and analyzing typical usage patterns, typical healthcare usage of the population through the state, through the existing now. And then they just did the actuarial modeling that they do. So this is the projection, but they were pretty confident on this. It took them quite a while to get to that conclusion. That was a long process. And then the second part, what was the second part again?
Oh, has there been any assessment of where there may be shortages of doctor or hospital capacity? And
yes.
are we addressing that so that when there is access increases, they're not waiting lists?
There's documentary evidence and anecdotal evidence that we do have a lack of providers in our state. So there was a bill to increase healthcare education, like training of healthcare workers, and I believe that passed this session. And so the state is well aware of that, and we know that there will need to be some expansion of the healthcare workforce. Also, better working conditions and benefits for them that make sure they can take their breaks, and the nurses especially, and that are on the front lines all the time. So yes is the answer.
I can tell you COVID has been brutal on the workforce. Okay, all right, let me see.
Catherine?
Oh, that was actually to Henry. I'm so sorry. I copied it wrong. Let me see. How much time do we have? Well, maybe we want to take go on a break to give us 15 minutes. Yeah.
Well, actually, Catherine, Henry, I think posed several questions related to labor, and I think this is really one of our key challenges in getting ourselves over the finish line. So if we could just sort of tease this out a little bit, and maybe hear a minute or so from each of the presenters as to what do you see as the breakthrough or the breakthrough pathway to getting labor solidly in support of single payer. So maybe if we could just do that, that'd be great. I think that'd be a real benefit to everybody in the room. So if we could just go through, Carmen, do you have any thoughts as to what needs to be done, really, even to assist the folks in New York and elsewhere, but also what are you learning in California that you can use, that you can share with others? Thanks.
Yeah, I think we've worked hard with our labor federation here in California. It helps that we have the California Nurses Association, who is really active in our labor fed and in the legislature. Really, having individualized meetings with different unions to say, like, we need to do this, and trying to explain to other unions that it is in the benefit of their union members and their bargaining rights and their collective bargaining strength to get healthcare off of the bargaining table, because we all know that healthcare is the leading takeaway in collective bargaining. Most strikes occur because of some sort of healthcare takeaway, and I think I think more and more rank and file folks and union leadership and some of these unions that have traditionally have really robust Taft-Hartley funds and health plans, that they're realizing that it's not a sustainable system where, you know, there's just going to be employers pushing more and more onto their members and cutting benefits, you know. And I think, you know, I do think what you said, what we were talking about earlier, which is like, there is a moment where like the health insurance companies and the healthcare prices are really driving worse and worse costs for Taft-Hartleys. And I think that that's something that we should use as an opportunity to explain, like, they're just going to keep on doing it. And another really big point that I think for labor is that, you know, rank and file folks, not everybody gets covered by these Taft-Hartley funds. They all know, like you and I, other people who don't have the benefit of a union healthcare trust plan, who are getting sick and dying and, you know, haven't gotten care because of COVID or, you know, for a number of reasons. And I think it's really important to have those kind of one-on-one conversations with union members who are part of, you know, rank and file members who are part of these unions that are in opposition to single payer, to really kind of dig down, because I think fundamentally, you know, it's a selfish position to say, you know, I have a good healthcare plan and no one else can have it. And I think, you know, union member to union member is really the way that we get people moving.
Okay, thanks. Barbara, I see you're putting a T up in your screen. Can we just get maybe Henry just to just sort of tease out a little bit maybe, or do you want to take a break? Is that what you're signaling, Barbara?
I was just saying 1 minute.
Oh, right. Great.
I agree with Carmen. It's an inside-out strategy. We're trying to work with as many rank and file groups as possible. A lot of education needs to be done because they're hearing all kinds of misinformation from the leaders. The leaders are not our friends in this situation, so we're trying to get as much going with with rank and file, with caucuses, and so forth, and take advantage of this effort to put us into Medicare Advantage, put retirees into Medicare Advantage. At the same time, we're trying to get some of the stronger supporters in the state Senate and Assembly to go to the unions and say, why are you doing this? This doesn't make any sense at all. You know, the state can provide, you know, you like traditional Medicare, you know, you think it's great, it's efficient, it's popular. We're just trying to expand it and improve it. So we're trying to get the state legislators to push back a little bit on the union leaders that they're trying to court by explaining that, in fact, this is a better deal.
Thank you so much, and for concise comments. Just one more question, if I could, before we take a break, and that is, you know, one of the codes that we need to crack here also is to win over faith communities and business communities. I know some of you are doing that work. If maybe among the presenters, if you could just jump up and just throw in a couple thoughts as to what you're doing to win over key business leaders as well as faith leaders. Why don't we turn to Sam? Maybe Sam, do you have some thoughts on that? And then Rana?
I do have some thoughts on outreach. What gives our SB 770 single payer task force coronary spasms is the concept that we will need to replace what people currently pay in premiums, out-of-pocket payments, self-funded plans with a tax. Here's the size of the tax that we are talking about. Half of the $40 billion annually spent in Oregon is already spent by some federal fund. So that leaves the other $20 billion that's being spent privately that we need to collect. $20 billion is larger each year than the total amount of spending from the Oregon General Fund. Translated into billboards and to outreach, we will double your state taxes. And we have to take responsibility for designing a plan that will do that. A tax plan of that size isn't going to be done with an extra nickel per cigarette package or taxing the rich. There are only 3 revenue streams in Oregon that can sustain $20 billion worth of taxes. And you can guess what they are. Their payroll, their income, and their sales. That's the bad news. The good news is a poll conducted in Oregon in 2019 by a rural Republican businessman discovered that over 60% of Oregonians would consider doubling or tripling their state income tax if they could get universal health care. When we appeal to these groups, unions, faith, rural, anyone, we need to lead with, we're going to replace what you already spend with the biggest tax you've ever seen in your life. Now, the taxes you pay, we anticipate you pay, will be less than what we think you're paying now in premiums, out-of-pocket payments, and self-funded plans. If you have the courage to write that check instead of to an insurance company, but you can write it to the single payer agency, your family can enjoy, and then we give them what single payer would provide them.
Terrific. Yeah, thanks, Sam. That's really excellent. And just a quick word then from Rana and John. Any thoughts real quick?
Yeah, I guess like not dissimilar from the labor unions, the leaders in the rank and file are on totally different pages here.
Right.
And small business owners in particular, in Connecticut, a new rate raise was recently approved that would mostly affect small businesses. And so I think, the CBIA here claims they represent business, but they're really insurance salesmen. And so I think that organizing small businesses that are really struggling to get help and are very impacted by extremely high rates if they want to provide insurance to their employees, getting a critical mass of those businesses to speak for themselves and not let the so-called community business leaders take over that conversation.
Terrific. Thank you so much. John, final word.
I put in the chat a link to 2 resolutions, the Massachusetts AFL-CIO and the National AFL-CIO. Technically, National AFL-CIO is pro-single payer. In Massachusetts, it's a different environment. Labor has generally is much more favorable to single payer, to getting out of the business, so to speak, because they are in the healthcare business, insurance business. And we enjoy good relationships. We just don't see, because of the political realities, we don't see the issue rising to the top of their legislative agenda. But the president of our state AFL-CIO used to be the lead co-sponsor of our bill in the Senate. So it's a little different, I gather, from some of the struggles in the other states. As far as business and other communities, on the business front, there's a national business organization. They have members in Massachusetts. They messaged their members about joining MassCare, and we got crickets. The sense I have, and all this also, it was a struggle to get them to testify, though some of them did testify at our hearing. I gather that business needs an organizer. The organizer of a business for single payer is not going to come from, not going to be a business person. And I think that may be similar to some other groups, though the faith community, which is again in Massachusetts organized, underdeveloped, the faith community has the advantage of having positions, sometimes 2,000 years old, in favor of single payer. So I think what we have to think about is the team of organizers that the state-based single payer group puts together and where it deploys them.
Terrific. Catherine Lewandowski, you want to take a break at this point? Thank you so much.
Yeah, we'll do like 4 minutes anyway. We can all run to the restroom, stretch our legs.
Very, very valuable. Thank you. Thank you so
Yeah.
much. Let's keep this conversation going. Absolutely. This is amazing. You folks are awesome. You're amazing. Keep it going. Let's jump in the room here and keep the conversation going always. Thank you so much, everybody. See you in a few minutes.
Okay, on that note of those of us that don't want to take a break, can we, or don't need to take a break, can we keep the discussion going?
That's Catherine's call.
I think that somebody would need to be, if Mike isn't going to be, it's up to Mike really, because we need to have somebody be ready to chase out any bad actors. If somebody were to pop into our conference. Mike, are you on here?
Yeah. And if that happens, we'll shut down and then restart and everybody just logs on again. But I'll stay on if the conversation wants to go on here.
You need
Great, thank you.
So on that, this is Consuelo Echeverria from Washington, Healthcare for All Washington. I actually have a question for anybody out there who's been working in promoting universal healthcare. How has this success been in outreach to rural communities?
I guess you have your answer.
Let me just throw a few thoughts from the Massachusetts experience. We have quite a shakeup going on inside the Democratic Party, which has a single payer plank, which is of course ignored. But a number of the smaller towns, Democratic Party committees across the state have formed a coalition. They got angry over the leadership of the party over some other issues, including sabotaging a single payer advocates candidacy run for U.S. Congress. But they have a certain amount of network, and many of them are more rural than urban because the urban committees tend to have other stressors. So we see a certain level of vitality there, but we don't have specific rural organizing.
Yeah, Chuck, we're in Maine have had pretty good luck getting some resolutions through the select boards and other governing bodies in rural communities. So that's one approach that seems to be working pretty well.
This is Barbara Harrison from Ithaca, New York. I used to be part of the Finger Lakes for New York Health Group, but in 2016, I wrote a storytelling workshop. And basically the response, and even from the campaign, was we're not interested in going into rural areas or working with marginalized groups. So I basically gave up. And basically that's the response I have gotten. There's really no interest in rural areas. I also wrote probably too much information, a PowerPoint on the health risks in rural areas, and no interest at all. So that has been my experience. I have not found people in this movement that I have come in contact with very interested in rural areas. And storytelling from my research, and I do have a background in community change and civic leadership, puts a level playing field in play. Rather than doing a presentation, it brings people into conversation. It is challenging to go into areas and to do the workshop, but if you do not bring people on board who are different from yourself or selves, you don't have an inclusive movement. And it makes it harder to pass the law. Why not have an educated public? So I have basically thrown up my hands. So that's all I have to say.
Well, we're not going to throw up our hands at One Pair States, so let's keep that going, that conversation. Thank you for the question and responses, Barb and other folks. Bill Bronston, are we into the next? I'm sorry, are we into the next session now, Mike?
Yes, we are. So that'd be great.
But Bill, if you can keep it very short, I'd appreciate it.
We don't have a model that addresses rural and environmental issues. We need a model that includes that kind of program analysis and structure. We've got to relook at our model. Our legislative models are outdated. Every single one of them are outdated.
So we'll hear more during your presentation about that, correct, Bill?
Yes, I hope so, for sure.
Okay, terrific. We'll look forward to that. Mike, Catherine, thank you so much again, everybody. Hope everybody was able to get in a quick break.